Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be talking about other causes of hypothyroidism. So we've talked about thyroiditis and how they can cause a transient hyperthyroidism and then a hypothyroidism. The causes of hypothyroidism that we'll be talking about in this section generally just cause the hypothyroidism, so there's no prodrome of hyperthyroidism, no transient hyperthyroidism. So because we're just talking about hypothyroidism, we're only going to have our hypothyroid guy pictured on this slide. You can see that he has cold intolerance, shivering, weight gain, dry skin, coarse brittle hair, brittle nails, constipation, fatigue, weakness, lethargy, decreased reflexes, and bradycardia, all of those things that you should associate with someone who is hypothyroid, pictured by this guy who is shivering in bed, had some weight gain, too tired to get out of bed, and has a very low metabolic state. And the first thing that can cause hypothyroidism of this type is iodine deficiency. And in iodine deficiency, we have decreased iodine. Remember, iodine is a very important precursor for our thyroid hormones. So when we have decreased iodine, we are going to have decreased T3 and T4 production because we don't have as much of a substrate that we need to produce T3 and T4. This is what is going to lead to our hypothyroidism. This hypothyroidism will cause all of the hypothyroidism symptoms that we mentioned above, as well as goiter. Remember, we talked about iodine deficiency as one of our causes of goiter. Toxic multinodular goiter or Graves' disease can also cause a goiter, but iodine deficiency can definitely cause this goiter as well. This often presents in patients in resource-limited countries. So a lot of resource-rich countries will put iodine into their food supply, so we don't have this type of iodine deficiency. But in countries with a limited supply of iodine who maybe aren't fortifying their food, this is where you're more likely to see an iodine deficiency. So for the purposes of STEP, it's usually going to be a patient who has lived outside of the US for some period of time. The management of iodine deficiency is just repleting their iodine, but we have to be careful with this, right? Because as we replete their iodine, we do not want to see a Wolff-Chaikoff effect. Remember, Wolff-Chaikoff, our hypothermic wolf, so bringing our T3 and T4 levels down. We definitely don't want to do that because we are in a hypothyroid state. We want to make sure that the T3 and T4 levels go up. We would prefer kind of a Jod-Basedow phenomenon here. So we just need to be careful and monitor as we administer the iodine, making sure that we don't have this Wolff-Chaikoff effect. Now, the next cause of hypothyroidism that I want to talk about is congenital hypothyroidism. And congenital hypothyroidism was previously referred to as cretinism because of the intersectional derogatory connotations of this term, both on the basis of race and disability. This term is no longer preferred, although you might see it in other study resources. I have chosen not to include it here for those reasons just mentioned. But remember, if a question stem does refer to cretinism, or if you see that written somewhere else, that is really talking about congenital hypothyroidism, which is one of the most common causes of preventable cognitive disability in the US. And this is an antibody-mediated maternal hypothyroidism. So if you remember, we talked about the only antibody that can cross the placenta will be IgG. And if you have these IgG antibodies in the mother that are attacking mom's thyroid and making her slightly hypothyroid, those can certainly cross the placenta and attack the fetal thyroid. This can cause fetal thyroid dysgenesis, so either the thyroid doesn't form at all, or it forms but is kind of inhibited and not really doing its full job, and that will lead to a decreased ability of the fetal thyroid to produce T3 and T4 later on. Now remember, however, while this fetus is in utero, it is also getting the T4 from mom, so we're not going to see the effects of the hypothyroidism until after the baby is born, and this may present weeks to months after birth because maternal T4 can cross the placenta, as we just mentioned. That T4 will ensure we don't have hypothyroid symptoms while our fetus is in utero, but after a baby is born and it no longer has access to the maternal T4, that is when you would see these hypothyroid symptoms present because we had this fetal thyroid dysgenesis. And the symptoms of this hypothyroidism are going to be a little bit different than all of our traditional hypothyroid symptoms. So I like to remember all of the P's. So we have a pot-bellied, pale, potentially puffy-faced child with a protruding umbilicus, protruding tongue, poor brain development, so some cognitive disability here, and then a hoarse cry and hypotonia. And if you look over here on our image, you can see a picture of a child displaying a lot of these symptoms. So we have this protruding tongue. We also have kind of this pot belly here. You can see this protruding umbilicus, a belly button that's kind of sticking out, as well as maybe a puffy face. So you look at the size of the face on this child before he has been treated for his hypothyroidism. And then you look over here at the face of this child and you can see that it's a notably less puffy face. So this is the child before they have been treated for hypothyroidism, and this is the child after they have been treated for this congenital hypothyroidism. You can see their belly is a lot less distended, their umbilicus is a little bit less prominent, their tongue tongue is back in their mouth and they do not have as puffy of a face. So I think this is a great photo to illustrate a lot of these symptoms of the congenital hypothyroidism. How we treat congenital hypothyroidism is with levothyroxine. So we just replace the thyroid hormone that our patient is unable to make on their own. We also should be screening pregnant women for hypothyroidism and thyroiditis because we want to know in advance if mom has any of these antibodies that could cross the placenta, attack fetus's thyroid, and lead to this congenital hypothyroidism so that we are ready to treat as soon as possible. Now, the third cause of hypothyroidism that I want to talk to you guys about is radiation-induced damage. So this can result from nuclear accidents, palliative radiation, or radiofrequency ablation. So this could be an accident at a job site, this could be an accident at a nuclear power plant, this could also be from palliative radiation that wasn't mapped appropriately or just necessarily needed to go through the thyroid to hit whatever tumor they were trying to get. So you might see radiation-induced damage in quite a few contexts. Pathophysiology of radiation-induced damage is just that the radiation is going to destroy the thyroid tissue. After you've destroyed the thyroid tissue, sometimes we do this on purpose in a radioiodine ablation, this will mean that we won't have any thyroid tissue left to produce T3 and T4, and that's why we get these decreased levels of T3 and T4 causing our hypothyroidism. The presentation is just that of a regular hypothyroidism, and the management is going to be levothyroxine again. And then we have another cameo of our Wolff-Chaikoff wolf over here by this radiation symbol to help us remember that if our patient is involuntarily exposed to nuclear material, nuclear waste, if there's a nuclear accident, we can help prevent this damage to their thyroid by providing potassium iodide, which via the Wolff-Chaikoff effect should halt the uptake of this radioactive iodine for several days, enough time for the radioactive iodine to leave your system, and we can use this Wolff-Chaikoff effect to protect our thyroid from the effects of radiation in the event of a nuclear accident. Next, I want to talk about euthyroid 6 syndrome. Euthyroid 6 syndrome is usually caused by a non-thyroidal illness. So if a patient has an infection or a patient is hospitalized for another illness, this is usually when you'll see euthyroid 6 syndrome. Because we have this non-thyroidal illness, we are going to have this inflammatory state in our patient, which will lead to increased cytokines, most notably IL-6. These increased cytokines are going to go to the liver and tell the liver to stop converting as much T4 to T3. So stop converting our T4 into that more active T3 version. And this can potentially be an adaptive mechanism because it does allow your body during times of inflammation when you're really, really sick to preserve energy during illness. Remember, if we're more hypothyroid, we are in a metabolically low state. So if we enter this metabolically low state during illness, perhaps that allows the body to save more energy to fight the illness later on. This is kind of hypothetical, but it is one proposed reason for the euthyroid 6 syndrome phenomenon. This, of course, will present with hypothyroidism symptoms, and you should see a non-thyroidal illness mentioned in the question stem. And then a key diagnostic finding that separates this from a lot of other causes of hypothyroidism is that T3 will be low, but T4 may be within normal limits, and then sometimes TSH is elevated, but not always. So I think that this presentation is really similar to de Quervain's thyroiditis once you enter the hypothyroid phase of that, because we have this non-thyroidal illness, some type of illness, and then we have a hypothyroid presentation after enough time, of course, in de Quervain's thyroiditis. But the thing that's going to be different is that in euthyroid 6 syndrome, usually they'll give you in the question stem that only T3 is decreased and T4 is within normal limits. Whereas if this was a de Quervain thyroiditis in the hypothyroid stage, you would see both T3 and T4 decreased equally. So I think that is a key differentiating factor to remember here that will make euthyroid 6 syndrome easy to differentiate from de Quervain's in a board style question. And the management here is the same as de Quervain's. It's none, it's self-resolving. We don't need to treat euthyroid 6 syndrome because it will resolve on its own. And then lastly, a couple other causes of hypothyroidism to be aware of. There are certain pharmaceutical agents that can cause hypothyroidism. We talked about these more in the T3 and T4 synthesis video, but certainly lithium and amiodarone are a few notable pharmaceutical agents that can cause a hypothyroidism, so look out for those in board style questions as well. Now, I know that was a lot of information. Let's quickly recap what we talked about in this video. So iodine deficiency is going to be a key cause of hypothyroidism in more resource limited countries. It'll present with this goiter. Then we talked about congenital hypothyroidism, and this will usually be in a child several weeks to months of age. It is caused by this IgG crossing the placenta and causing fetal thyroid dysgenesis. The presentation is all of these P's. Remember this picture over here, and we treat it with levothyroxine, and it's very important that we treat this because this treatment with levothyroxine can completely change the presentation and prevent cognitive disability in these patients. Radiation-induced damage, remember that we use our Wolff-Chaikoff effect, potassium iodine, to prevent this if there's a nuclear accident. And then euthyroid 6 syndrome, remember that you can differentiate it from other causes of hypothyroidism like de Quervain's because you might have this decreased T3 with a potentially normal T4. And then how do they ask you about this on a board style question? Well, something they might ask you is a 3-week-old female is brought to the pediatrician for paleness, abnormal cry sounds, and poor tone. Labs reveal decreased T3, T4, and increased TSH. What is the embryological origin of the organ responsible for this patient's symptoms? So it's giving us a picture of a 3-week-old female with paleness, abnormal cry sounds, and poor tone. And then we know from the labs that this is a hypothyroid issue. And because it's in a child, I am immediately going to think about congenital hypothyroidism. And then it asks us for the embryological origin of the organ responsible for this patient's symptoms. So remembering all the way back to our embryology video, you should remember that the thyroid forms from the endoderm between the first and second pharyngeal pouches. And that is how you would answer this question. And I hope this video was helpful, and I'll see you next time.